All right, why don't we get started? So I'm Jenna Kahn and we have Archie Pelham. We are happy to start this session off on safety and quality initiatives. We have a wonderful team today who have a great discussion and talk for you. A couple ground rules. If you have questions or comments, you can put it in the chat. Please make sure to put it to everyone instead of just to host and panelists. And with that, anything else, Archie?
No, I think we're really excited to have this, in honor of Patient Safety Week, which is coming up March 13th through 19th. So maybe we can start by having everyone introduce themselves. Should we start with Dr. Evans, and then we can go around and yeah.
Sure, Archie, thank you. I'm Sue Evans. I'm a radiation oncologist at Yale with a strong focus in patient safety and quality. Also, I am part of the Radiation Oncology Health Advisory Committee, which is the analysis arm of the Radiation Oncology Incident Learning System, which is the National Incident Learning System for Radiation Oncology, sponsored by ASTRA and AAPM. And Javonda Julian and Dr. Chera are part of that group as well. So if anyone has any questions about that, we'll probably be talking about a little bit about that during the session, but wanted to open that up as well as background. Shall we do Dr. Kissling next?
Sure. I'm Kelly Kissling. I'm a medical physicist at the University of California in San Diego. I am a member of the AAPM committee working group actually for implementation of TG100 methodology, which is a focus on quality and safety approaches. And I also lecture to groups for the IAEA and in other forums about quality and safety in external beam and brachytherapy. Derek?
Yeah, hi everybody. My name's Derek Brown. I'm also a physicist at UC San Diego. Have been involved in quality and safety initiatives for probably about the past 10 years. I'm also a founding member of the Treat Safely organization, which develops and deploys educational programs around quality and safety in radiation oncology. And a huge thank you to the organizers. Tremendous effort went into putting all this together and herding cats, so to speak, and just really appreciate you inviting us all to be here. Javonda, Julian?
Hi, everybody. My name is Javonda Julian. I work for Mary Bird Perkins. I have been a radiation therapist for about 10 years. I'm also the radiation therapy quality lead, which I focus on patient care, training, and of course, any efforts toward patient care, anything similar to it. We have 7 centers, so that's pretty much everything for me. Dr. Bishop?
I hope either you're having lunch or it's afternoon tea. Welcome and thank you for joining our ROVER's discussion. Thanks for inviting me to be part of this. I'm a radiation oncologist. I was at University of North Carolina. I just started my first week at a new institution, the Medical University of South Carolina. But I'm on ROHAC with Dr. Evans and Javonda, and I am also the vice chair of quality and safety in my current institution. Naomi?
Can you hear me? Hi, I'm Naomi Schechter, and I have been in radiation oncologist for over 20 years, and a good part of that career has been in quality and safety as quality assurance director at UCSF and at USC. I'm currently vice chair of the ASTRO Patient Safety Committee, and I'm chair of the ACR Practice Parameters Committee, and I have worked with the AAPM, and much of my work has been on referrals from Sue Evans. So I'm very grateful to be here, and I love members of this group, and thank you.
Awesome. Okay. Let's go ahead and jump right into it here. I'm going to share my screen. And Kelly's going to kick us off with a brief presentation here.
Okay, thanks, Derek. So first I'll briefly go over the agenda. which we're going to start off with a super quick high-level intro to safety and quality in radiation oncology. And then we're going to get to the good part where we're going to watch some videos that are reenacting actual events that happen. And then those will be followed by panel discussions with everybody you see here. But first we're going to start with some poll questions to get to know our audience. So please take a moment to fill this out. Okay, we have quite a mix, a lot of medical and physics residents, students, medical physicists, radiation therapists, and dosimetrists. Great. Okay. When you're ready, next poll question. Have you ever been involved in an incident investigation? Okay, so a mix of answers, majority saying no, but some people have been. So we all have a little bit of different experience here. Okay, have you ever been aware of a significant, did it disappear for everyone else? Okay, are you part of your department's quality improvement committee? Okay, most people know, but a small percentage are. Great. And this is the last one to kick us off. What's the primary purpose that you came here today? Hopefully nobody's in the wrong place. Ooh, okay, everybody is supposed to be here. Want to learn, further your skills, student learning about rad-onc, and passionate about safety. Great, okay, good mix. Okay.
Kelly, this means we have lots of experts in the audience to help us out if we flounder. We've got at least 8 additional panelists.
Yes, feel free to participate via the chat when you think we've gone astray. All right, so we're gonna just start with super high level intro to safety and quality in radiation oncology. We're gonna split them up because there's kind of different safety and quality, but they're very interrelated. I'm gonna start by talking about safety, which is the most intuitive. We can think about it in terms of freedom from mistakes or harm to patients that was unintended. And when you think about the question, are we safe in radiation oncology? There's actually some data about this. So we have 3 different sources we can cite here. The first is from New York State, and they collected information about serious incidents, which were incidents that needed follow-up care. And they estimate that about 1 in every 10,000 courses has a serious incident. We also have data from our industry partners from Varian. And they estimate that an incident that puts a patient at risk of harm occurs in 1 in every 50,000 courses. And then finally, we can look at data out of the UK, where a clinically adverse event occurs in 3 out of every 100,000 courses. And so when we look at these in terms of percent, they range, these are all about in agreement, and they range from 0.003% to 0.01%. So these are pretty low, they're not 0. And we can compare these to maybe how we're doing to other sites or other medical specialties. So we have a poll question for you. How do you think the incident rate in radiation oncology compares to wrong site surgery? Is our rate higher Are we lower than surgery, or are we about the same? Okay, yeah. So a lot of people think lower. We're actually about the same as wrong site surgery. Okay. From this one data source, they quote a 0.003% risk of wrong site surgery, which is on the lower end actually of the estimates that we have for radiation oncology. So we're on par, maybe slightly higher. So probably that gives us an indication we maybe have room to improve. But let's look at it in a different way. How do you think we compare to another complex industry, the airline industry? Do you think we're higher, lower, or about the same? Yeah, most of you got it right. We are actually quite a bit higher. And if you look at the numbers on the next slide, it's actually a few orders of magnitude that we are higher. This figure from 2010 reports a 0.00001% risk of serious injury on a US domestic flight. So what that tells me is that we could be doing a lot better. You know, we're not that different than the airline industry in terms of complexity. You know, they're making planes fly. They have lots of different people and processes involved and upkeep of planes and training. So let's step back and think, why are they maybe doing so much better than we are in radiation oncology and medicine? And there actually is an explanation for that. The airline industry and other high reliability industries have several tools that they use to improve safety in their practice. And I'm just going to give a high level overview of some of these tools, but there's so many. One group is what we refer to as retrospective tools. And so these are anything that happens after an actual incident or maybe a near miss, an almost incident occurs. And it could be a causal analysis where you look at trying to figure out why it happened. You can then also learn from that mistake or incident and implement mitigating factors. And also you can share information with the field so that nobody else makes that same mistake or has that same incident. There's also prospective tools, and these are anything you do before an incident happens. So you try to predict where the risk in your process is, and then you put in mitigating factors or change your process to reduce that risk or avoid any incidents happening. And then the final tool I'll briefly mention is safety culture. And this is the attitudes and values and beliefs of your organization and the people in your organization that safety is of the highest importance and that everybody in that organization has a role to play in the safe practice. And it's also a very valuable tool that's used in high reliability industries to achieve safety. So with that, I'm going to let Derek take over and talk to you a little bit about quality.
Excellent, Kelly. Thank you so much. So yeah, I mean, definitely room for improvement, right? If these high reliability industries can do it, they're, you know, radiation oncology is complex, but no less complex than, you know, flying an airplane with hundreds of people in it. So definitely room for improvement. Okay, so Kelly talked about safety in radiation oncology. I just wanted to talk a little bit about quality in radiation oncology. And, you know, quality can mean a lot of different things to a lot of different people. But for the purposes of this discussion, let's define quality, or let's take a look at quality just in terms of whether or not the prescription is delivered within consensus determined tolerances. So a little bit of a sort of very technical definition of quality in radiation oncology. So if we look at this graph here, on the center, we have the prescription dose. To the right, we have overdose, and to the left, we have underdose. And here's what we would hope that things look like in radiation oncology in terms of the distribution of whether or not the prescription is delivered within consensus determined tolerances, right? Everybody gets, there's some sort of range, but everybody gets some benefit. Unfortunately, we know from things like the New York incident and other sources that doesn't always happen, right? There are catastrophic events in radiation oncology, right? So we know we have these catastrophic overdoses, and we know we have these catastrophic underdoses. So what does everybody think about this sort of representation? Either the patients benefit or they're harmed. It's kind of in our minds what we have, but I think it's probably a false representation of the distribution of patients with respect to prescription dose being delivered within consensus determined tolerances. Something more realistic is probably something like this, where there's a continuous distribution from acceptable treatments to harmful treatments. And if we can all agree on that, then we can start to look at this in a little bit more of an interesting way. So if we believe this distribution, then for sure there are patients that fall into these areas here where they receive treatments that do not result in obvious injuries, but for whom the probability of the desired outcome is compromised. So slightly lower tumor control probability, slightly increased risk of complication, right? But not enough that we can actually pinpoint that to an overdose or an underdose, right? And let's call those two areas there the quality gap. And it's a little bit of hand-waving math coming up, but what we're going to try to do to the best of our ability is try and figure out how many patients in the US fall into this quality gap. Okay. So if we believe this distribution, and let's take all the most conservative numbers that we have, okay, just because we don't want to overestimate this thing. So we're going to be super conservative. If we believe that the distribution can be represented by this Gaussian curve, and if the event rate, again, very conservatively, is 0.001% per course, and if we take a threshold for harm of plus or minus 10%, again, this is conservative, right? Typically, we would want to deliver our dose within plus or minus 5%, if not plus or minus 2%. So we're being pretty conservative here. Then the area outside the middle 20%, that's that plus or minus 10%, is 2.6%. Okay, and we just pulled that out of statistics manuals, books, using a standard deviation of 4.5%. Okay, so 2.6%. Let's figure out how many people that represents in the US. So the US population is about 330 million. Cancer incidence rate is about 0.5%, and roughly half of cancer patients will receive radiation therapy during the course of their treatment. Okay, so that means that we have around 825,000 patients per year receiving radiation therapy, and 2.6% of that is just over 20,000 patients per year that fall into that quality gap. No obvious harm, but certainly suboptimal treatment. So 20,000 patients per year in the US alone. That's a lot, right? And we've taken all the most conservative numbers that we have available to us. So I kind of want to hear from the audience. Is this realistic in your experience, in your clinical experience? Do you think it's fewer patients than this, more patients than this? Interested to hear your thoughts. Think it's about right. Yeah. Some people think it should be a little bit more. Some people think it should be a little bit less. And this is kind of a fairly typical response that we get when we ask this question. So 20,000 people, as a patient going through this system, how would that make you feel if someone told you 20,000 patients per year were falling into this quality gap? It's pretty, it's kind of a pretty dramatic number. And I think it kind of motivates us to look at things and do things a little bit differently and a little bit better in radiation oncology. So do you think there's anything we can do as medical professionals to reduce the number of patients that fall into the quality gap? Yes, 100%. Thank goodness, because otherwise we'd just be throwing up our hands and hoping for the best, right? Excellent. Yeah, there are things that we can do. Kelly already talked about a lot of them. We can pull some of those tools from the high reliability industry and start using them in radiation oncology. And we've been trying to promote that for a long time. They really do work and they really do make a big difference. So is quality and safety an issue in radiation therapy? I think between Kelly and I think we would agree. Certainly we can do better. And really what we're trying to do is kind of shrink this Gaussian curve, right? Get rid of the number of patients that fall into that quality gap. Okay, enough from Kelly and I. Next, we're gonna watch a couple of videos, one at a time, and then we're gonna have a panel discussion about what happens in these videos. And these videos are reenactments or recreations of actual incidents that occurred in radiation oncology departments in the US. So we gathered all the information from those incidents. We talked to the people involved in those incidents. And then we got a, a film crew, because we're in San Diego and film crews are a dime a dozen. And we actually made these incident recreations. So let me go ahead and tee that up. This is our first video, and it has to do with therapists at the LINAC.
In this video, we are recreating an actual error that happened in a clinic. In this clinic, there are 4 linear accelerators, and they treat about 140 patients per day on those 4 linear accelerators. They treat everything from simple to complex cases, including daily image guidance, SRS, and SBRT. The staff is comfortable with these complex cases, and they've been working in this environment for a long time. It's a friendly and collaborative environment, and everyone gets along, including physicians and physicists and therapists and dosimetrists. Matt is a very experienced therapist with over 10 years in the field. Bree is a junior therapist with about 5 years, all working in this department. Matt and Bree haven't worked together in this department, but they know each other very well. Matt has an excellent reputation. In fact, the chief therapist has said that he trusts Matt with the most complex cases and also to train junior therapists. Due to staffing levels today, Matt has been working alone. But the department has a policy that 2 therapists must be working on the linear accelerator at all times. Bree has been covering the CT simulator, but the CT simulator is slow today. So the chief therapist has asked Bree to help Matt on the linear accelerator. Their next patient is Mrs. Smith. It's the second fraction of the boost plan for Mrs. Smith. The films were approved yesterday by the physician.
Hey Matt, how's it going? CT schedule is really slow right now, so I was sent over to help you out. It's great we finally get to work together.
It's going to be great to work together. We haven't done that before. It's really busy right here. Can you run up to the lobby, grab Mrs. Smith? She's a lung patient on her boost, and come back and you can help out over here.
Perfect, I'll get her right away.
Thanks a lot.
Hi Mrs. Smith, how you doing today?
Hi, I'm doing fine.
Good, good.
What's that noise?
I'm sorry Mrs. Smith, but unfortunately that's a fire alarm. We're gonna have to hold on for just 1 minute.
Let's head outside to the safe zone until we can figure out what's going on.
Okay, I'll follow you.
Mrs. Smith, we're so sorry about the delay. We'll get you set up here and get going. There you go. Okay, Mrs. Smith, we're all set. Keep holding still for us. That was a little confusing. Why were the nurses allowed to keep working and we had to wait outside for the all clear?
Yep, definitely confusing, but I think we'll be able to catch up pretty quickly.
Matt has his own method to review the setup images. And it's acceptable practice in this department for each therapist to use the method that they prefer. Let's see where they are in the process.
Okay, I think this match looks okay. Spinous process is aligned, the carina is aligned. I think we're good here. Bree, what do you think about this area near the manubrium? It's kind of a large shift, but I've been treating Mrs. Smith from the beginning, and she lines up differently each day.
Sure, Matt, looks pretty reasonable to me.
Okay, we're ready to treat then. This is Mrs. Smith, lung, 180 centigrade per fraction, fraction 2 of 6 on her boost.
Good.
Matt has been feeling uneasy about Mrs. Smith's treatment, and at a break later in the day, Matt asked Bree to review the setup images again.
Hey Bree, something's not sitting right with me about Mrs. Smith's images. You mind taking a look with me?
Sure thing, Matt, but I'm sure it's fine. Let's have a look.
Okay, ribs look good. It's kind of hard to see with the bad image quality though. Oh no. I think we might be one vertebral body off. Do you see that as well?
Let me see here. Yep, looks like we treated about 2.5 cm superior from the isocenter to the plan.
Okay. Let physics and the chief know. I'll enter this into the ILS and call a physician.
Okay.
Okay, everyone. I think a lot of us will be sort of maybe familiar with an incident like this. I think it's a fairly typical high occurrence kind of thing in the field of radiation oncology. Kelly, do you want to walk us through the polling questions to kick things off?
Sure. All right. We have another polling question coming your way. Which of these do you think might be contributing factors to the incident? And I guess, it might be a multiple choice, so you can maybe just pick your favorite.
Might be allowed to do more than one.
Are they allowed to do more than one? If it lets you pick more
Yes.
than one. Okay, yeah, I think it did. So one immediate, I guess, thing I'm taking of this is that you guys appreciate that there's probably more than one contributing factor to an incident. Distraction related to the fire alarm, the match relative seniority to Bree, when you're rushing, which happens all the time, a lack of a policy for kind of stop the line when there's a big shift, or a lack of standard method for image review. Matt and Bree had different approaches. Also, the image was suboptimal, making it hard to see. And then Bree didn't really, at the time of treatment, give it a quick look. She deferred to Matt on that. So I think these are all great contributing factors. I guess, should we, do our next poll question? It's the last one before we have our panel discussion. So what do you think? Once they realized the incident occurred, what was the next step that the staff should take? Should they not tell anyone what happened and sweep it under the rug? Tell the patient immediately right away before doing anything else, or report it to their quality and safety committee and supervisor? Okay, yeah, most of you got it, what I would think would be the right thing to do. Not that we don't want to tell patients when things happen, but first we want to figure out more details, of what went wrong and what the effect was before we alert the patient. And I think this is probably a great place to start our panel discussion. Does anyone want to jump in with some thoughts right away?
Dr. Chera, I'll call on you. How do you look at this incident? What are your thoughts about how you might approach this situation?
Yeah, I mean, it's easy to jump to, blame the therapist for how could you make this mistake, right? I mean, that's our first human instinct. But in the introduction to the vignette, it's brought up that that senior therapist has 10 years experience, one of the best therapists. And the point I want to make is that error-free performance is not attainable for anybody, no matter how good people think you are or you think you are at your job. And so I'll make that one point.
That's a perfect point. I think, that's a really great point. I think one of the points I wanted to make vis-a-vis Kelly's illusion was that, like we have here, there's no single causal factor, right? There's multiple causal factors, and Eric Ford did a nice paper on causal factor taxonomy. And in their data, they looked through and found that the number of identifiable causal factors was between 2 and 14. And the median number was 7. So I think that rings pretty true to most of us, that, you're going to have a multitude of issues that can be attributed to any event. So Javonda, I'm wondering if you can talk to me a little bit about your thoughts for this situation from a therapist perspective, and how you guys handle large shifts, for instance, at your institution, and what the process looks like.
So the first thing that jumps out with me is the fact that he was treating by himself. ACR, most people's policy is that at least 2 therapists needs to treat on a machine at all times. It's not that he's not competent, it's just that sometimes you just need a second eye, especially when you're in the chest and the spine. Everything starts to look alike. The chest has certain little landmarks, like the sternum that he could have looked at, that was actually contoured out, but again, he was rushing and different things like that. So mistakes happen. When it comes to my institution, any shift, excuse me, guys. Excuse me. Any shift over 1 cm, we have to recombine. So that's something else too. You may have to come back to me.
Javonda, I'm just gonna give you a hard time. Mary Bird Perkins is in Baton Rouge. So Javonda's hoarseness, maybe because Mardi Gras just happened 3 days ago. So I'm just gonna throw that out there as a possibility, right?
Most of mine is because our weather changes constantly. It's hot, it's cold. All of this is always just stopped up. So I apologize for that, guys, but yes. Over 1 cm, we recombine the patients, and definitely a second eye at all times.
You can. Great. What about you, Dr. Schechter? What are your thoughts about this situation? How would you, what do you feel are the important considerations for the patient when, what would you say to a person who says, no, we should tell the patient first right away, absolutely right away? What would your reply to that? What would your thoughts be? And what would you want to know before you had that conversation with the patients?
Okay, so to first answer your question, I had the experience as a resident where somebody, I think they fell or something hit them with a machine, and it was my instinct to just tell the patient, but then it created more drama, that was unnecessary, and more fear because I didn't have the answers. And I think I really should have gone to my attending and then to the, appropriate safety personnel in the department. And I have learned, as, I've been in the safety world, to do those assessments comparing to the original plan and your plan, and really see with the critical structures what dose was given. And also sometimes when you have a long course of therapy, you may be able to correct for and not have harmed the patient. So it depends on how many fractions you're giving to the patient. Certainly with SRS, we have higher risks. One of the things though that I saw, that when I saw this video cold, I was like, how come they didn't do a timeout? And I thought this was going to be about Miss Smith. There could be a lot of Miss Smiths. And then you get called out, and they didn't check, maybe there was a picture of her, but people can look alike, and they didn't check their wrist and do the number. So those timeout might seem boring, but it's really important and will help you prevent. Because I thought maybe that's why there was a big shift change. So. Right. I think also not to, if when we're in a teaching environment, not to ask a leading question, because I think he suggested it looks good, right? And she's like, yeah, it looks good. So maybe just like really like try and have a poker face and let them assess and see how they would do it, and then maybe fill in how you might.
I think it's really important too, you know, these sorts of muscle memories and being conscious of your processes. For myself, I found that if I'm not driving the mouse at IGRT, I'm not actually reviewing it, right? Like I can't follow my eye fast enough to somebody else's mouse movements and be able to look at the anatomy. If I'm not driving, I'm not looking. There was a comment about, you know, how there was a comment if there weren't two people treating. I think, you know, what Javonda was referring to was that when Bree initially joined Matt, she said, I've been at the CT Sim all morning. I heard you were treating by yourself. I came to help you out. So I think, you know, you're right. This at the time there were two people treating, but Matt spent the whole morning treating by himself. So I think that was, you know, certainly a concerning issue. And there, to Naomi's point, there are a few things about the video, right? That was the fastest 3-point setup I've ever seen. And they viewed her tattoos through her gown, obviously. I think Deborah is maybe one of the admins in the department. So of course she wasn't about to go topless for this video, as dedicated as she might be, not really in the cards. So I think, you know, what do people think about what sort of policies and, you know, corrective actions that could be taken in this situation?
So can I just piggyback with one comment from what Naomi was saying? You know, he sort of asks her in a very leading way, you know, I think it looks good. What do you think? And it's also, you know, this super senior person, he's, you know, an educator in the department, and she's relatively new. So there's also this like interesting sort of power dynamic that's happening between the two of them. And then on top of that, he asks her like, oh, I already think this looks good. What are you really going to tell me it doesn't look good? Come on, I have all this experience, right? So for me, that's a really interesting part of this video as well. Okay, back to Sue's question. How can we, what's lacking, or how are we going to fix this thing?
I think that, you know, back to my initial point, you know, no blame. I mean, you know, 99.9999999% of us that come to work are not coming to work to purposely make an error. We already talked about, you know, there's all these contributing factors that predispose us to make these errors, and this could happen to anyone. And so first thing is, you know, not to blame, you know, and part of the reason you don't rush to tell the patient is you don't know the whole story. So then, you know, there needs to be some kind of departmental level, you know, investigation investigation is not the wrong word, you know, evaluation of what happened. And then to figure out, you know, then you realize, oh my gosh, there's all these contributing factors that really played a role in this. And then sometimes it's just that learning helps improve the culture. And maybe you have all the policies and procedures in place, you have the most educated people doing it, but having the discussion around the event is the intervention in a way. A lot of times that's not what it is. A lot of the time, very few of the times do you need to implement a whole new policy. Sometimes you have to, you know, and you realize, oh, you know, we should have a policy like Yvonne said, that if there's a shift over a CM, we should recomb beam, you know, but a lot of times it's just talking about it.
Yeah, and I think in the video right at the end, I don't know if you caught it, but Matt said, let's record this in the ILS. And there he's referring to recording the incident in the incident learning system. And that's a really key way to kick off kind of the, you know, investigation or whatnot into what happened, to determine these contributing factors. And then you can really, you know, end up turning that into a positive experience where everyone recognizes that we're all human, and that instead of blaming the person, maybe think about their environment that they were in and what else can be changed to help them do their job as safe and best as possible. But the first step is just making sure there's awareness of what happened. And as we know, this is a common mistake in radiation oncology. And so, you know, not only sharing it within your department, but with other departments would be a great way, you know, because you don't want to make any mistake, but you definitely don't want to make it twice.
So it looks like we have 19 minutes left in our discussion. Should we go on to the next video to allow adequate time? Is that okay?
You answered that question before you could have possibly read the text too.
No, we're just like that.
Seriously, unbelievable. Okay, here's the next video. This is physicians and contouring. Again, a recreation of an actual incident that happened in a clinic here.
In this video, we are recreating an actual error that happened in a clinic. In this clinic, there are 4 linear accelerators, and they treat about 140 patients per day on those 4 linear accelerators. They treat everything from simple to complex cases, including daily image guidance, SRS, and SBRT. The staff is comfortable with these complex cases, and they've been working in this environment for a long time. It's a friendly and collaborative environment, and everyone gets along, including physicians and physicists and therapists and dosimetrists. In this video, we are recreating an incident in which a 6-year-old child is being preoperatively treated for a left thigh sarcoma.
Hi, this is Dr. Paravati in radiation oncology. I need the MR images fused for patient Julie Peters. Yes, they're essential since this is a sarcoma case. I reviewed them with the radiologist, but I can see they haven't been imported or fused. The dosimetrist must have forgotten to do it earlier today. Is there anyone left there at this hour who can do this for me? No? Okay. Well, I didn't want to do this, but I'll have to leave them for Dr. Gillespie to finalize because I'm leaving for a conference in 30 minutes. Thank you for checking.
The dosimetrist completes the treatment plan and then calls Dr. Gillespie to review and approve it. The dosimetrist is unaware of Dr. Paravati's note asking that the MR image be fused to the CT scan.
Hi, it's Dr. Gillespie. I'm reviewing this case for Dr. Paravati. The contours were complete, the prescription was in. I think the plan looks really good. I understand the patient needed to get started right away, so I can sign off on this. Yeah. Okay, great, thank you. Bye.
The case was scheduled to be presented at previous chart rounds, but was continually delayed because of lengthy discussions about other cases.
Julie Peters is a 6-year-old child with a right thigh sarcoma. We're treating preoperatively using a 3-field technique to 50 gray and 25 fractions. I believe she's currently on fraction 15 of 25. Can we have the MR brought up so we can review the contours and the treatment plan?
I approved the plan without checking an MR.
I know I put an electronic note in there to check the diagnostic MR before finalizing the plan.
I didn't see a note. I'm pretty sure there wasn't a note.
Hold on a sec. Let me check the chart. Here it is. The note is in the treatment setup notes.
I never checked treatment setup notes. I didn't see that.
Oh wow, looks like we missed that one.
The MR images were fused to the treatment planning CT scan, and it was determined that the target volume was too large. Due to the larger fields, there was a concern that there could be an increased risk of growth delay and infertility. Dr. Gillespie decided to redraw the target volume and complete the patient's treatment. Upon reviewing the case in detail, it was determined that the target volume was about 30% larger than it needed to be. The extra volume was irradiated to a dose of 3,000 centigrade.
All right. Another round of polling questions here.
Okay, let's look at some contributing factors. Select all that apply. rushing to get out of clinic before vacation, lack of handoff, lack of policy for fusion instructions, lack of a naming convention to designate volumes or preliminary volumes, and then failure for treating physician to review a pediatric case promptly upon return. Yeah, so similar to before, there are lots of contributing factors. I think I would agree with all of these. And then we have one final poll question. Do you think the involved staff should be reprimanded? Yes or no? Okay, about a quarter saying yes and 75% saying no. Maybe we'll flip it to some of the panelists to see what they think about that last question.
Dr. Schechter. Oh, Dr. Schechter, do you want to take that one? What are your thoughts?
Oh, I don't know about everyone else, but I had this sinking feeling. I felt so bad for them, right? They all already feel bad. So, and I think there was good intentions. There was no bad intentions in this process. So I think that there was a lack of, experience, knowing where the attending was going to look for that note, like that they didn't, wouldn't look in that section. And there's definitely a lesson learned about, I really liked that one about the preliminary naming, like a different name, so that the dosimetrist or the physicist who would be that intermediary who could be that stopgap to have not let it move forward without the attending sign off. So certainly the attending's responsibility is to look at all the contours and check everything, and before it actually would move to a planning stage in my mind. So I think there was like, yeah, that step that's a great usage of that preliminary naming device. So I'm not, no, I don't think reprimanding, although, you can see that from a patient's family standpoint, they're like, someone needs to get in trouble for this, so I can see where, people would feel that way, but I don't think that's what's going to make it better for the next patient. And I don't really think anyone intentionally did anything wrong. So no.
Dr. Chera, what are your thoughts?
Yeah, I mean, if it's, a repeated, this happens in this physician's practice over and over again, then it needs to be a corrective action, for that. This is such a complicated case, a pediatric patient who's getting preoperative radiotherapy. Typically in our departments, there's like one person who's like a pediatric specialist. Other departments have multiple. But in these complex, complicated cases, I personally do not want to hand it off to someone else, and I don't want you to hand it off to me to look at it. It just causes a lot of anxiety in me because I feel like I'm going to miss something. I mean, recently I had to cover one of our faculty went on paternal leave, and it's prostate cancer. I haven't treated prostate cancer since I was a resident, but yeah, even that made me uncomfortable approving those plans. I thought I was missing something, and it was actually there's one plan that I was like, I don't feel comfortable signing this. Let me ask someone else to look at it. So I guess my point here is that handoffs, we should always minimize handoffs, and if we do them, that's just setting up to make a mistake, and there's got to be a lot of effective multiple lines of communication, verbal, written, text, like multiple layers, and I would say actually the best countermeasure is not to hand off a complicated case.
Yeah, I think, Sue, I think you'll know this better than I do, but is there not some decent data showing that the cognitive workload through NASA TLX scores is actually substantially higher when physician is doing handoff, like covering another physician's case as to when they're doing their own case? Very
nice. I like that you referenced the UNC data, Dr. Chera's previous institution. But yeah, there is. Dr. Chera, you can comment about that if you want to expand upon that data a little bit more, but definitely increased workload. And I would echo Dr. Chera's comments, you know, for better or for worse, at my institution, we hardly ever cross cover because we have the cloud, which is the beautiful tool that allows you to look at your plans from Turks and Caicos, so wherever you may find yourself, which is a double-edged sword. But I think, you know, certainly, you know, Joint Commission, right, has labeled handoffs and transitions as one of the major contributing factors for sentinel events and significant medical error. So, you know, as Dr. Chera said, to not hand off or to have a very detailed, specific handoff regarding the case. And, you know, having sort of standard ways that you know, deal with these things. I think we all have some functional OCD in terms of, you know, one would have thought there would have been direct communication, not only with a covering physician, but also direct communication with the planning dosimetrist. So that's, you know, communicated really well. Javonda, I'm wondering if you can talk a little bit about how, as a therapist, you handle treating a patient on the machine when something has gone wrong with their treatment. How do you deal with that situation? What sort of things can you do to make people comfortable continuing to receive treatment? What are your thoughts about how you've handled that sort of situation in the past?
So basically, we do not treat with just one therapist here. That is totally against our rules. But if something does happen, we have a hard stop. The doctor should be called, the dosimetrist should be called, and a physician should be called. Everybody has to be on one accord before any treatment can be completed. If someone cannot be reached, the treatment is halted for that day. Of course, we'll just kind of talk to the patient. Don't give specific about what happened, but kind of tell the patient, you know, we're going to delay your treatment for a day. You need to talk to your doctor, et cetera, et cetera. All of our stuff is entered into roles, of course. And pretty much here, every moment for us is a teachable moment. So whether you have 1 year of experience or 15, every day we try to come in and just learn as much as we possibly can. We have a great staff here, the doctors, the physicists, the dosimetrists, they're all willing to help. So that's pretty much it. What jumped out about this video for me, though, is communication. Like Sue was saying, he easily could have called the dosimetrist at night, or if he had that physician's phone number, he could have reached out. I'm not sure where he was vacationing to that he didn't have cell phone communication, but this was tough. I'm pretty sure he felt just as bad as the other doctor did.
Yeah, and I think maybe this is a great time to plug some not very exciting things, but standardization in terms of how communication happens, maybe where fusion orders take place. We already talked about naming conventions for targets, or, you know, even a standardized process for handing off a checklist. All these are things that can help prevent these errors that very easily happen anytime communication or handoffs are needed. And so I think they're worth putting some time into, even though they may not be, you know, the most cutting edge thing you're doing in your medical practice.
Yeah, there's almost too many ways to communicate now, right? You know, there's in the EMR, there's like 20 different places you can write a note, and there's cell phones, pagers, whatever, all this, you know, so you're right, you got to standardize how you communicate.
So Kate wants to hear from our panelists, Kate Hinton-Lang, who I'm sure could give us an earful about this. Best practices for the panelists on providing feedback to the entire department to show that concerns, good catches, or near misses entered into the incident learning system have not only been raised, but also have been addressed. So how do we keep the ILS from being a black hole? Who wants to take this one?
I guess I can jump in first. This is a really great point. It definitely feeds into your safety culture. You want to continually encourage people to participate and enter information into your incident learning system. But if they never hear feedback from it, people are going to eventually not bother to take the time. So whether it's, you know, this one thing happened, it's minor, we're going to track it to see if it's a big issue, or if it's a regular issue, then we need to take a step, you know, acknowledge that you're watching it, or for bigger things, report back what the mitigation actions are going to be taken. is almost a necessity because no one's going to keep reporting. And then also you can use it to spin in a positive way, because usually when things happen, someone comes in and does something good to either help or prevent. And so reporting back and giving positive feedback too, like, you know, physicists caught this thing or therapists caught this thing and they were able to, you know, prevent it or change something late at night, give them a little shout out in the department, can, you know, turn that into a positive experience too.
Dr. Chera, do you want to talk about what you guys have done with sort of good catch recognition sorts of things?
Yeah, so, you know, there's good data saying that you have to give feedback if you want people to continue to report, and also if you want to, you know, make positive change, you have to give feedback to the people who are submitting good catches. So, you know, we give a departmental kind of a State of the Union quality and safety meeting that we do during our regular academic meeting, where we go over all these good catches and recognize people for submitting them, for actually doing the countermeasure, and publicly thanking them. And we give them a small coffee card and go to Starbucks. There was one time where I didn't recognize anybody, and I don't know why I did that, but afterwards, so many people were upset that I didn't recognize anybody. And recently, we found out that Starbucks is not going to be able to take our whatever money from the departmental money, and that caused an uproar because people don't want to go to the cafeteria to get the coffee. They want to get their coffee from Starbucks because it feels nicer, it's closer, it's better coffee. And these small little things, you know, sometimes people say we say thank you too much in healthcare, and I totally get that, especially during COVID. You know, I'm tired of being called a hero. Thank you for doing this, and thank you. You're right. You want to say thank you, but you don't want to desensitize people when you do that. So, you know, carefully selecting how you say thank you and the way you do it, it's important. It's a careful balance.
I'll also just add, I feel like sometimes as a physicist, our job is always to be like, no, you can't do that, or you did this thing wrong, go back and fix it. So it's always helpful for us to hear like, thank you for catching that, or thank you for noticing my PTV looked weird, but I did it on purpose, you know, just, you know, so we don't always feel like we're kind of being the naysayer.
All right, we've got 60 seconds left, so I think it's just time to thank our audience for some great participation. And I'll let Archie and Jenna, Dr. Khan and Dr. Pullum plug perhaps the next session. Is that what's on the agenda?
Yes. Start up the presentation.
Just a big thank you to everyone for tuning in, and great discussion. Really good to be here with everybody. Thank you.
Yes, thank you so much to our panelists. It was a great discussion, great videos, learned a lot. And thank you to Nav. And our next session is going to be a debate on abscopal effect. So it's going to be abscopal versus schmascopal. And Doctors Welch and McBride will be debating. So we're going to do this with VBPN. So sign up on April 8th.